Hello, I am Bruno van Herendal. I'm the medical director of ISGE, and I would like to welcome all of you to this webinar. I think this is a quite important webinar on the diagnosis of endometriosis, as we know that most patients suffer from a delayed diagnosis. And this is why we asked Antonio Simone Lagana to talk us through the possibilities to enhance our diagnostic possibilities or our diagnostic accuracy in diagnosis endometriosis. Antonio Simone Lagana was researcher at the Università dell'Insubria in Varese, Italy, and he is that is my university where I was professor at contratto from 1993 to 2005. And he now moved to Palermo, where he is involved at the University of Palermo, mainly in the oncology research. He's still a researcher there, and I'm pretty sure that he'll move up to a professorship in quite soon. He is also in the editorial staff of different journals, and so without further delay, I would like our IT man to start his presentation. Derek, it's up to you.
Good evening, I am Antonio Simone Lagana and I work at the Unit of Gynecological Oncology of the Department PROMIS at the University of Palermo in Italy. I'm very glad to be with you for this webinar promoted by the International Society of Gynecological Endoscopy. And for this webinar, we will discuss about the diagnosis of endometriosis. I will start to share my screen. So regarding this presentation, I have no conflict of interest. When we refer about endometriosis, of course, we refer to a chronic progressive disease characterized by the presence of endometrial-like tissue, gland stroma outside the uterine cavity. We have two main symptom and signs. The first is, of course, chronic pelvic pain that for definition lasts for more than 6 months. And the second main symptoms is infertility that affect up to 50% of the patient. I remember when I had this type of my phone in my hand, I was very happy because it allowed me to connect with other people. But if we look to what is in our hand today, of course, we understand that we did giant step forwards in our technologies. So during the same period, what changed about the endometriosis diagnosis? If we search on PubMed, the word endometriosis, we will find more than 25,000 items about the topic. But despite many efforts to date, we don't know the exact pathogenesis of the disease. We have just theories. We do not have a definitive cure for the disease. We know that pharmacological treatments allow just a temporary relief, which rapidly disappears after discontinuation or interruption of the treatment. And we know that endometriotic lesion and symptoms may recur even after proper surgical excision, especially without postoperative medical therapy. One of the main problems when we speak about endometriosis is the diagnostic delay. Indeed, I will show you just this study published in 2003 in Human Reproduction, in which the authors, the leading author was the group of Maurizio Brau, my friend Maurizio, expressed some concern about the diagnostic delay that was typical of endometriosis, and this paper in particular discussed the cohort of Brazilian women. If we look at what was published years later, here we are in 2012 by the group of Professor Udelist, the situation didn't change so much because this is a cohort of women affected by endometriosis in Austria and Germany, and even in this cohort, 10 years later, there was a long diagnostic delay to get the right diagnosis for women with suspected endometriosis. And so if we look to what is today in our literature, the situation unfortunately is still the same. This is a call to action published in the American Journal of Obstetrics and Gynecology in 2019, in which the group led by Hugh Taylor proposed a call to action for the clinical diagnosis of endometriosis. And in particular, in this paper, the authors suggested that there are 4 million of reproductive age women that are diagnosed with endometriosis in the United States, and there is estimated 6 out of 10 women with endometriosis that are still undiagnosed. So the situation is quite concerning, in my honest opinion. So we didn't do a great step forward in the diagnosis of endometriosis, and in any case, there is still 20 years after the first publications by Maurizio Brown in Human Reproduction, there is still a long diagnostic delay. So this is quite concerning in my honest opinion. So I was asking to myself, are we so unskilled at diagnostic endometriosis? Do we use wrong tools for the diagnosis of endometriosis? Do the tools we use have a low accuracy? So I asked it to myself, and I will ask to you what's going on with this topic, because we didn't improve in the diagnostic pathways of women affected by endometriosis or with suspected endometriosis. As in other fields of medicine, of course, when we address a patient, we have to do history taking, clinical examination, imaging. We can use biomarkers, and in particular for the field of endometriosis, we can perform diagnostic laparoscopy. So in the next part of my talk, I will discuss all these elements with you in order to understand what we can do and what we can improve in each field of this the diagnosis of endometriosis. If we take a look to the available guidelines, the one published by the American College of Obstetricians and Gynecologists was published many years ago. There is also the one published by the American Society for Reproductive Medicine, was published also many years ago. And then we had, I'm speaking in the past, and I will show you why. We had the guidelines published by the European Society of Human Reproduction and Embryology, published in 2014. Starting from May 2019, we worked on a new update of this guideline by the ESHRE. And we published this year the new guidelines, the updated guidelines about the management of women affected by endometriosis. This was the guideline development group. I was part of the group led by Professor Kiesel from Münster, Germany. And honestly, we did a giant work for the update of this guidelines. So I will be very glad if you would like to take a look to what we did. First of all, regarding history taking, I will start with this citation from William Oster from the Hopkins Hospital in Baltimore. If you listen carefully to the patients, they will tell you the right diagnosis. And this is what I used to say to my trainees, because the first part of the game, of course, is to listen to our patients, because if we listen carefully to the patients, they will address you to the correct diagnosis, or at least they will suggest you fairly what the problem is, and so you can decide which pathway you will follow to ask for imaging, for biomarkers. If you are in doubt, you can call a second opinion, another sonographer that is more expert than you. But the first step is, of course, always a good history taking. When we speak about endometriosis, anyway, we have to check for a particular element of our field, because unfortunately, we know that pelvic pain is not always correlated to the stage of the disease. In particular, this was very well highlighted by Paolo Vercellini already in 2007. And in this case series, the author, finally in the conclusion, suggested that they can confidently exclude measure and clinically important association between endometriosis stage and the severity of pelvic symptoms. In particular, they concluded that the intensity of pain is determined not by the type and extension of implant per se, but by the interaction between endometriotic lesion and the sensory afferent nerve fibers. And this is particularly important when we address the patient with endometriosis. This was later confirmed by other studies published years later. This is one of the studies published in 2015, in which the association between the presence and stage of endometriosis and severity of symptoms was found to be very marginal. So when we refer to endometriotic women, we have to keep in mind that the level of pain is not always related to the stage of the disease. Indeed, there are women with the stage 1, 2 endometriosis, so early stages, that are a lot of pain. Conversely, women with stage 3 that have not the same level of pain. And this is extremely important if we look to what happens when we refer to chronic pelvic pain and endometriosis. Indeed, we know that chronic pelvic pain in endometriosis is related to three different potentially overlapping mechanisms: one nociceptive, one inflammatory, and one neuropathic pain. Indeed, we know also that nociceptive stimuli can be exacerbated or decreased based on the hormonal status of the patient. And we know finally that the central nervous system plays a key role modulating the nociceptive stimuli incoming from peripheral lesions. And this is a very old publication by Riley et al. In 1999, in which the authors found that the threshold for pain stimuli was dependent by the hormonal status. In particular, the authors found that somatic sensory pain thresholds were significantly lower by approximately 30% in the immediate premenstrual and menstrual phases of the cycle when estrogen levels are low. So this is extremely important because, of course, when we refer to pain in women, we have to consider, especially chronic pelvic pain, that this could be modulated by the level of hormones. If we look to what the new ESHRE guidelines suggest, the guideline development group found and suggested that the evidence to predict endometriosis based on clinical symptoms alone is weak and incomplete. In addition, endometriosis should be considered as possible diagnosis in women presenting with such clinical symptoms, as it may result in an early diagnosis of endometriosis and in improving quality of life of the patient, of course, because we can perform early diagnosis and early treatment of our women. This is another very important question for the topic. Does the use of symptom diaries or questionnaire compared to traditional history taking lead to improved or earlier diagnosis of endometriosis? According to the ESHRE guidelines, this is the main conclusion for this question. Although currently there is no evidence that a symptom diary questionnaire app reduces the time to diagnosis or leads to early diagnosis, the guideline development group considered their potential benefit in complementing the traditional history-taking process hesitates in objectifying pain and empowering women to demonstrate their symptoms, because this is a very important subtopic, because sometimes when the patient declare pain symptoms to the physician, sometimes the physician is not taking them seriously. So probably using also app to monitor the pain symptoms might help also the physician to track what's going on in this patient. Regarding clinical examination, clinical examination in women suspected with abdominal endometriosis includes, of course, physical examination of the pelvis, but also the inspection and palpation of the abdomen, with the aim to facilitate diagnosis and to optimize treatment decision. Of course, when appropriate, vaginal inspections should include a speculum as well, bimanual, and rectovaginal palpation. This is extremely important because when it is to my trainees, they always started to do ultrasound, and this is not correct in my honest opinion. First, we have to do bimanual and vaginal if appropriate examination, and then we can perform ultrasound. This is extremely important because you can feel what's going on, especially with the rectovaginal septum. And this was already studied and investigated in a publication in 2011, in which the authors compared the diagnostic performance of transvaginal sonography. That you can see the accuracy here. That was very high for the endometriosis of the ovary, uterosacral ligament, Douglas patch, vagina, rectovaginal space, urinary bladder, and rectosigmoid area. But if we take a look to the diagnostic performance of vaginal examination for the preoperative diagnosis of endometriosis, of course, it is lower than ultrasound, the transvaginal ultrasound, but for instance, for urinary bladder endometriosis, for rectovaginal space, and for the vagina, the diagnostic performance is almost overlapping to transvaginal sonography. It is crystal clear that with vaginal examination, we are not so accurate, for example, for endometriosis of the ovary, or even worse if we refer to the uterosacral ligaments or rectal sigmoid area. So if we take a look to what the ESHRE suggests about clinical examination, in the new guidance, we will find that clinical examination, including vaginal examination where appropriate, should be considered to identify deep nodules or endometriomas in patients with suspected endometriosis, although the diagnostic accuracy is not satisfying, it's low. We have to be honest about this point. In addition, in women with suspected endometriosis, further diagnostic steps, including imaging, should be considered even if the clinical examination is normal. So, if we have a normal clinical examination, this doesn't mean that endometriosis is not there. And let's skip about the imaging, that is probably the most important part of the game when we speak about the diagnosis of endometriosis. And I would like to start with this citation by John Lennon in Imaging. Don't just listen to this song, you need to feel it. And why I'm telling you this part of the story? Because, of course, when we speak about endometriosis, we have to consider ultrasound first for the imaging of female pelvis. We should use the most informative, less invasive, and less expensive modality to avoid radiation whenever it is possible. Hence, ultrasound imaging should be the first imaging modality used in women with pelvic symptoms, so also for endometriosis. In addition, ultrasound technology has advanced very quickly, and many practitioners still provide basic 2D ultrasound imaging without implementing the newer modality that ultrasound imaging offers, which emphasizes the need for education and dissemination of this information. In particular, This is the most important point, in my honest opinion, when we speak about transvaginal ultrasound imaging, because compared to CT scan, RMI, we have the possibility to use, when we perform ultrasound, the tenderness-guided ultrasound. That is becoming the most effective way of the detection of implant of painful deep infiltrated endometriosis in the pelvis. This because we can push our probe and test if this lesion is painful or not. And we can do this just with fingers and with transvaginal probe. We can't do this with CT scan, with RMI. So please keep in mind this when we perform transvaginal ultrasound. And this is another very important point. Inexperience should not justify ordering an MRI or CT scan. So we have to teach our trainee how to perform transvaginal ultrasound to detect endometriosis. When we refer to ultrasound, transvaginal ultrasound performed for suspected endometriosis, we have, of course, to check for the tenderness of the tissue, and this is the first element. And the second main important element is the mobility of the tissue. I will show you just this video just to have a clear view of what I mean for tenderness of the tissue and mobility of the tissue. And this will lead us to get extremely important information to the pelvic structure that we are investigating. Another very important point is that we need a very clear method about how to explore the pelvic area. Indeed, for example, we have the possibility to use very easily, for instance, the sliding sign. And the sliding sign is very easy to use. If you look to the literature, you will find that the checking for the sliding sign is extremely easy to learn. Indeed, the learning curve is extremely fast, and there is also a good inter-observer correlation between two trainees, of course, as was shown in the slide. Of course, we have also the possibility, when we explore and we check the pelvis by ultrasound, to perform 3D sonography. And some authors suggested this technique as first-line imaging technique in a cost-effective evaluation of gynecological pelvic disease. When we perform ultrasonographic evaluation of the pelvis, of course, we have to move step by step. According to the IDEA group, so the International Deep Endometriosis Analysis, it was led by George Condus and my friend Stefano Guerriero. Of course, we have some additional steps. The first one is the routine evaluation of the uterus and of the annex, plus the ultrasonographic signs of adenomyosis or the presence of or absence of endometrioma. The second step, and in this way we will start with the dynamic ultrasonography I showed you in the previous slide. A second step, there is the evaluation of transvaginal sonographic soft marker, for instance, the site-specific tenderness and ovarian mobility. The third step is the assessment of the status of the Douglas pouch using the real-time ultrasound-based sliding sign. And the fourth step is the assessment of deep infiltrating endometriosis nodules in the anterior and posterior compartments. Of course, it is the most difficult part of the game. This is the first step. As I said, the routine evaluation of the uterus and of the annex. So we'll check for sign of adenomyosis and presence or absence of endometriomas. When we refer to endometriosis and or adenomyosis, we have to keep in mind, as was clearly shown by the group of Renato Serracchioli in Bologna, that approximately 20% prevalence of adenomyosis in patients affected by endometriosis. So we have to keep in mind that 1/5 of the patients with endometriosis have also adenomyosis. So this is extremely important when we check for the adenomyosis in women that we know that have already a diagnosis of endometriosis. When we refer to adenomyosis, of course, we have to keep in mind that we have to use the MUSA group recommendation for checking the uterus, the wall of the uterus, and the signs of adenomyosis. In particular, we have to check for a discrepancy between the anterior and posterior walls of the uterus, and fan-shaped shadowing, and of course, hypoechoic area that are little vascular cysts, especially subserosal, in the subserosal area. And this will address us to the diagnosis of adenomyosis mainly. The second point that we have to check during the first step of the IDEA statement recommendation is to check for ovarian endometrioma. About this point, I would like to stress once again that only 50% of patients exhibited a single isolated endometrioma with a mobile ovary and no other signs of pelvic endometriosis, adenomyosis after vaginal ultrasound. In particular, we know that ovarian endometriomas are indicator for pelvic endometriosis and are rarely isolated. So probably when we will find an endometrioma on one or bilateral ovary, we have to check also for other signs of deep infiltrating endometriosis in the pelvis. In particular, left endometriomas were found to be associated with rectal deep infiltrating endometriosis and left uterosacral ligament localization. And bilateral endometriomas correlated with adhesions and patch of Douglas obliteration. And this makes sense, of course, because if we have kissing ovaries with the two big endometriomas, of course, I guess, that when I enter in the pelvis in laparoscopy, I will find Douglas patch obliteration. And of course, if I will find large endometrioma on the left ovary, I expect also when I enter in laparoscopy in the pelvis that I will find also some small or large nodules in the uterosacral ligament, or even worse, on the rectal area. And this is extremely important because, of course, the preoperative mapping of endometriosis is allow us to do a good plan of our surgery and to address the patient to a skilled surgeon, for example, if we suspect endometriosis, a deep infiltrated endometriosis of the rectovaginal area. This is the second step, so the evaluation of transvaginal sonographic soft marker. For instance, the site-specific tenderness and ovarian mobility. Of course, how we do it. This is a paper that was published in 2009 by the group of Antonia Testa and Dick Timmerman. So we are speaking about the Gemelli group. And in this paper, the authors suggested to investigate the presence of pain and define the location of the most painful sign. So we have to do the pain mapping of the pelvis. We have to examine the elasticity of the pelvic content. So we have to keep in mind that malignant masses are rigid, solid, and non-compressive structure. We have to assess the spontaneous movement, such as the peristalsis of the structure. We have to detect the content of the pelvic mass with the hypoecholic appearance. We have to evaluate the mutual sliding of different tissue layers. For example, I'm referring to bladder, uterine septum, and or of the different pelvic organs. In particular, we have to assess the pre-movement of the ovaries in the pelvis in order to understand if they are stuck to their ovarian fossa or not. And finally, we have to better define the outline of a pelvic lesion, regular or irregular, if there is adherence to the surrounding organs. This is the third step, so the assessment of the status of the Douglas pouch using the real-time ultrasound-based sliding sign, and this is extremely easy to perform. In particular, this is the way in which we elicit and demonstrate the sliding sign in anteverted uterus and in retroverted uterus. And this is the fourth step, so the assessment of deep infiltrating endometriosis nodules in the anterior and posterior compartment. And this is, of course, to be honest, the most difficult part of the examination of the ultrasound for endometriosis or suspected endometriosis. Of course, we have to keep in mind how the anatomy of the anterior posterior compartment is. And in particular, when we refer to the bladder, of course, we can have some bubble sign in the bladder, as in this video, or as in this other video, we can have an endometriotic lesion at the base of the bladder. Of course, this radically changed the approach that we do during our surgery. So once again, I would like to highlight how much is important the preoperative mapping of endometriosis before to enter in the abdomen. Let's take a look to what is here, this bubble-like sign here. And of course, we can have also endometriosis that is near the ureter, so the so-called kinking sign. So this is also extremely important, because if we didn't detect the endometriotic lesion near the ureter, near one or bilateral ureter, of course, we can risk of missing this lesion when we enter in the pelvis in laparoscopy, because of course, in order to check for this lesion, we have to open the retroperitoneum on one side or both sides. So of course, this mapping of endometriotic lesion near the uterus plays a key role for the plan of our surgery. Of course, when we refer to rectovaginal septum deep infiltrating endometriosis, we have to keep in mind that true rectovaginal septum dye is in type 1, 10%, of the type 2, that is here in this picture, of 65%, and the type 3 is 25%. Of course, the type 2 and type 3 lesion accounted for the so-called fornicial vaginal deep infiltrating endometriosis. Of course, this is the anatomical counterpart of what we found during the transvaginal sonography. In this slide, you can see the cervix, the vagina, the rectum, the regiovaginal septum, some small fluid there. Of course, this is a lesion of the rectovaginal septum. In this case, it was very easy to identify this lesion, because if we know how to look at the pelvis, and in particular at this area, the rectovaginal septum, of course, we can identify deep infiltrating endometriosis and endometriotic lesions in general. Another very important point is the ultrasound, the uterosacral ligament nodules of deep infiltrating endometriosis. In this slide, I will show you a longitudinal view with a normal uterosacral ligament and a transverse view of the normal uterosacral ligament. And here, I will show you a nodule of the left uterosacral ligament, just to have a look to what it means to have an endometriotic lesion in this area. Of course, these are other picture of uterosacral ligaments nodules affected by deep infiltrating endometriosis. In particular, below you can find a lesion of the so-called torus of the uterus, so between the two uterosacral ligaments. On the after part of the slide, you can find typical nodules of deep infiltrating endometriosis in the uterosacral ligament. This is other pictures, just to have a quite easy view of what means to have an endometriotic lesion of the uterosacral ligament. And of course, we should check also for bowel endometriosis. Of course, this is a bit difficult to check. Of course, the sonographer should have a good experience to check for bowel endometriosis. It is not so easy to detect endometriotic lesion of the bowel. Anyway, when we check for the bowel, we have to check for the muscularis externa, the submucosa and mucosa, the lumen and the subserosal layer of the posterior rectum. And of course, we can also find, if you look at this area in this way, also lesion by endometriosis. In particular, in this slide, I will show you a typical mushroom cup nodules of endometriosis of the rectum, and this is quite easy to see these big lesions of bowel endometriosis. I will show you also this type of endometriosis affecting the bowel. Of course, in this slide, I will show you just very big nodules. Please keep in mind that, of course, it is not always the situation like this, because there may be some smaller lesions that are very hard to be identified at transvaginal sonography. And before to finish this part about ultrasound, I would like just to let you know that as International Society for Gynecological Endoscopy, we published this position paper in the European Journal of Obstetric and Gynecology and Reproductive Biology about the structured report for dynamic ultrasonography in patients with suspected or known endometriosis. And in particular, I will show you just the abstract of this publication, but if you are interested, of course, I recommend you download the paper and to take a look to what we discussed in this position paper as the International Society of Gynecological Endoscopy. And in particular, we recommended the adoption of the terms, definition, and methods proposed by the International Deep Endometriosis Analysis, so the IDEA group, for the ultrasound assessment of patients with suspected or known endometriosis. And in particular, we recommended also the use of ancient classification to summarize the findings in a standard fashion. And this is extremely important because we have to speak the same language when we read the report of sonography by endometriosis. Of course, this is the ancient classification of endometriosis that everyone knows about this, and we suggested to use this type of classification when we finish and write our ultrasonographic reports of suspected or confirmed endometriosis. So, in my honest opinion, the message that I would like to send you to take home is to teach our trainees, because as I said, when I started my lecture, my presentation, is that inexperience is not the correct, is not the justification to ask for CT scan or MRI, never. So let's speak about biomarkers. When we speak about biomarkers, we spend you just few slides, and we refer to what we decided to say as ASHRE Guide Development Group, and we finished to say that clinicians should not use the measurement of biomarkers in the endometrial tissue, blood, measure or uterine fluids to diagnose endometriosis. This is because overall, no biological markers currently exist that reliably can rule in and rule out endometriosis. But of course, we discussed about single biomarkers, multiple biomarkers, if we have to check biomarker in the serum, blood, urine, if we have to come back to CA125, to vasoactive intestinal polypeptide, substance P, neuropeptide Y, calcitonin gene-related peptide, if we have to use microRNA combinations, and so on. But we decided not to suggest to check for any biomarkers. And this is overlapping to the last Cochrane systematic review published in 2017 about this point by Nissenblatt and collaborators. Indeed, if you read the conclusion of this systematic review of the biomarkers that were subjected to the meta-analysis, none consistently meet the criteria for a replacement of triage diagnostic test. And overall, none of the biomarkers displayed enough accuracy to be used clinically outside a research setting. So, of course, we can continue to perform research about biomarkers for endometriosis, but we cannot use them in clinical practice to date and so far. This, in my opinion, mainly because the studies published so far were not so harmonized with each other. And this is the reason why Niloufer Ramioglu et al. In Fertility and Sterility in 2014 published this part of the World Endometriosis Research Foundation Endometriosis Phenomenon and Biomarking Harmonization Project in order to stress and to standardize the fluid biospecimen collection, processing, and storage in endometriosis research. And I agree that this is extremely important when we refer to research in endometriosis field, in order to speak the same language as, for example, for the ultrasound in endometriosis. We have to speak the same language and to write our ultrasonographic report consistently all over the world. Even when we refer to biobanking for endometriosis research, we have to work in the same way. And this is extremely important also to compare the results of different studies when we speak about biomarkers in endometriosis. Regarding the HSRE guidelines, clinicians are recommended to use imaging, so ultrasound or MRI in the diagnostic workup for endometriosis, but they need to be aware that a negative finding does not exclude endometriosis, particularly superficial peritoneal disease that is extremely hard to detect by ultrasound. I mean, MRI has a better diagnostic accuracy, of course, compared to ultrasound for superficial peritoneal disease, but if we refer to transvaginal sonography, peritoneal disease is extremely difficult to detect. In addition, in patients with negative imaging results or where empirical treatment was unsuccessful or inappropriate, the guideline development group recommends that clinicians consider offering laparoscopy for the diagnosis and treatment of suspected endometriosis. And finally, the guideline development group recommends that laparoscopic identification of the endometriotic lesion is confirmed always by histology, although negative histology does not entirely rule out the disease. But in any case, we have to keep at least a biopsy and send to the histology to know what's going on in that pelvis. So always ask for histology when we perform laparoscopy for suspected endometriosis, of course. And I would like to thanks for your attention, and let's open the field of discussion.
Okay, guys.
Okay,
thanks, Derek. Hey, Sino.
Hello, everyone.
Thanks for joining.
Of course.
Bash or Anneli, I'll start with you. Do you have any questions, or what would you like to see discussed in this particular?
If I can comment, thank you very much, Antonio, for a great lecture. I just wanted to comment one thing. You said very well that ultrasound has to be done according to structure and also MRI. But what I see in my work is that people go inside the operative laparoscopic surgery, and we tend to forget that every operative laparoscopy is actually diagnostic laparoscopy. So we have to start with diagnosis, and we have to do a structured laparoscopic overview of the intraperitoneal cavity in every single laparoscopic surgery. So sometimes I'm struggling to make my general surgeons or colorectal surgeons to understand that at least look downside, that if you're looking for a reason for pain, so there may be endometriosis. And now they are much more aware because I've trained them, but it takes time. So the gynecologist kind of has to remind them that there is pelvis and you have to look also down there. So maybe the reason for pain is there. But thank you.
Thanks for this wonderful comment. I perfectly agree, because in my honest opinion, and it's what I am trying to teach to my trainees, to my residents, if you are in doubt, you have to ask for a second opinion. It is not acceptable anymore to enter in the pelvis looking for endometrioma, and then you have to perform a bowel resection, so call it a senior surgeon. This is not acceptable anymore. If you are in doubt, and this is valid even for me, for senior colleagues and other people, if you are in doubt, ask for a second opinion. It's not a fail at all, because we have to do the best management for our patient. I am sure that also Sina, ciao Sina, agree with this point, because I'm sure that someone took a patient with endometrioma in the OR and then has to call Sina for a bowel resection. Of course, Sina is not happy anymore.
Well, I mean, I agree, Antonio. Excellent presentation, and you covered the area very nicely, especially the part that is good to examine and relate to the ultrasound. When you do it yourself, that ultrasound would work like a GPS for you. So these are excellent points that you brought. And what you said is better to go in the OR and you find something is too complicated, stop and bring the patient back, versus going too far, pushing too far, and causing irreversible complication. So these are excellent points you brought up. So I agree. And not everybody needs to go and have MRI. Some people do it routinely, part of their protocol. Some people cannot. But for example, in our practice, we occasionally do 3D CT colography, which is Johan started it from South Africa. And actually, sometimes it gives good images, better than anything else. So individualization is an excellent point. You brought it up.
And another point that I would like to stress, if you allow me, just to underline what you said, Sina, is the importance of the first time surgery, because sometimes people are referred to not so skilled surgeon, and when the disease is not removed from the whole pelvis and you enter for the second laparoscopy, you will find a disaster, especially when we have endometriosis associated infertility. If the woman is not managed in the correct way, the second time laparoscopy is a disaster.
The sliding technique and everything that comes to that, because there are articles mainly from Asia that stress on the fact that you have a very good sensitivity, but specificity for vaginal ultrasound, and I think you stressed that too. But the let's say, the combination of the vaginal ultrasound where you feel it, and I dealt a lot with pelvic pain in my career, and so what we did was actually try and combine these the two of it, and between let's say irritable bowel syndrome and endometriosis, diagnosis can be very tricky, and that's where you have to train the people well, especially doing ultrasound. I started ultrasound in '76, for God's sake, and well, we definitely progress in that. And I think I think you stressed the point very well, that you have to combine these, and that you have to do also what Sheena says, and it is individual. It is an individual patient, and you have to actually adapt your techniques to the individual patient. My problem that I would suggest that we discuss is the idea someone is getting on the is that, well, what is your opinion on the fact that we see very often that endometrial cells infiltrate the nerves, and they're not just around it, but they really infiltrate, and they look like if they go with the nerve system, and that is of course then what I saw in my career is that even with the smallest infiltration, you could have patients with severe pain, with severe discomfort, like you also described, especially in the premenstrual phase, where you got a swelling and then a compression of a lot of things. Any comments on that, Antonio?
Yes, thanks for the wonderful comment that allowed me to open also this small field, because it's a niche field. Since I moved in Palermo, you know that I'm working with Vito Chiantera, that is an expert about neuropil biology.
He'll be in Agadir. He'll be also in Agadir when we talk about ISON meets the ISG. I think that's very important. Yes, yeah.
Exactly. Yeah. And working with him, I'm seeing a lot of sciatic nerve endometriosis, or in general of hypogastric nerve endometriosis. And of course, these are very and extremely hard situation to manage by laparoscopy or robotic surgery. And probably we have to study more this topic, because of course we don't know what happened, why endometriosis infiltrate the sciatic nerves or the hypogastric nerves, and we don't know where the disease starts. Probably, in my honest opinion, the retrograde menstruation is not enough to explain this type of retroperitoneal disease. It must be something else, about embryological origin or something like this. But of course, I agree that even a very small lesion that infiltrates hypogastric nerves or sciatic nerves and so on may play a big role in the pain perceived by the patient, and once again should be managed accurately by expert surgeon only.
Yeah, Antonio, one thing I liked about your extra, I mean, I liked all of it, but that 4-point technique when you talk about on ultrasound, and specifically, I mean, the visceral slide and focused and direction, these are excellent points that would help on a clinical exam. But even when I do it, and I do a 3D ultrasound, sometimes it's hard to see the ureter and the relationship to uterosacral ligament. Do you have any tips on that?
I have to be honest, what I said during my lecture was taught by Professor Stefano Guerriero, you know, that is expert about this field. And when we start to teach our residents about checking the ureters and the bladder and so on, it's not easy, because we need not hours but months to for learning curve about retroperitoneal spaces, even about, for example, parametrial endometriosis. It's extremely hard to detect. And even if we enter in laparoscopy and we found normal pelvis, of course, if we don't open the spaces, all the spaces, as for example Marcello Ceccaroni is used to do, we will not find parametrial endometriosis or ureteral endometriosis. I mean, it's a hard topic because, of course, I'm not suggesting to open all the spaces in all the patients. This is not correct, of course, because we can make also very hard damages to the patient. But of course, if we don't have a good preoperative mapping and we find a normal pelvis, of course, we are not sure that we are not missing something. And we have to balance between opening all the space, Okabayashi, Lasco, and all the spaces, and not to open them to avoid any potential damage.
Wonderful.
Bruno, can I come in for 1 second, please?
Yes, please, of course. It's up to you. You just come in.
We have people from all over the world with various levels of skills that are listening to us.
Sure.
Can I take this discussion wee bit little? What Antonio said was, listen to the history, as William Osler said.
Mm-hmm.
Regrettably, in private practice, everybody is in a hurry to get on with the work so that they can keep their schedule going in time. Now, from the history, the things that come to my mind is that any young girl, lady, women presents with secondary dysmenorrhea, and that has to be differentiated from primary dysmenorrhea, number one. And they present with vomiting, and the school teacher sends that child home every month. Or the lady at work misses work every month. The history is talking to you already, Antonio. You now have to present yourself to say, in my mind, this is endometriosis unless proved otherwise. Let me now work diligently. Over years, I've realized that the babies that I delivered, and I'm in practice for more than 35 years delivering babies, the mothers bring those girls to me and say, you delivered this one, you fixed this one. She's now being sent from school by the teacher every month, and I don't know what to do. I feel helpless. I give them the brochure of endometriosis and say, Mommy, go and read it. She comes back to me and says, Doctor, do this thing, laparoscopy, do it. Do it. To my surprise, over the last 10 years, and I have innumerable young ladies that we've taken from high school to university and walked them down the aisle and looked after them in the journey of life. Early diagnosis is prevention of stage 3, 4, and rectovaginal nodule. So your original slides, what you said, in the last 10 to 20 years, we have not shifted our ability to early diagnose. And because we have to do a surgical procedure for accurate diagnosis, we are shirking from that responsibility. I think possibly there is a moment in time to do that diagnostic therapeutic laparoscopy on a young teenage girl instead of doing pharmacological gymnastics. To an extent, there is a place for it. And I'm not saying there isn't. We have to be accurate to say which one do I take to theater as early as possible. I'd like to hear from my learned colleagues, what is their thinking on this particular point?
I will leave the word ladies first.
I guess I have to comment that I agree that early diagnosis is very important, and to me, I I totally agree. I see the same thing, that young girls are coming, and there are actually two ages now. The first thing what I don't like is that when the menstruation starts, then they say to the girls that, well, this is the life of a woman and you have to suffer for the pain. So that's wrong. The other age is that they start to know a lot about endometriosis. So basically every person who has a little bit of menstrual pain, they start to find me and they say, do I have endometriosis? Do I have endometriosis? So this is the other age. So this is exactly like you said, we have to be accurate. So the first thing is that take a very good history. And usually I start medical therapy first. So if I get an effect that I get the periods not pain, then I don't do laparoscopy just to diagnose endometriosis. I say the adolescent, the mother and the young teenager that you may have endometriosis. I make a very thorough ultrasound like Antonio just said, all the steps and even beyond, to find out, does she have already some kind of adhesions? Does she have already some kind of endometrioma? Does she have already hydronephrosis or some kind of dangerous situation? So if they don't have any dangerous situation, then I can confirm that for the mother and the adolescent, the teenager, that you don't have anything dangerous. I put on the birth control pills. If we get pain down, that's it. I don't touch you, but I follow you. I will check you because you may have endometriosis, but I don't know that. But I don't take her to the OR. But I do take those patients to the OR who don't react to the drugs. They still stay in pain. So I don't start to change different pills. No, let's try another one, and then let's try another one, and then I put the Mirena, and then I take it out, and then I do start to take neuropathic pain pills. No, I don't do that. If I have to change already to second pill and I don't get an effect, I take her to the laparoscopy and I make the diagnosis, and then we will see what's the next. So that's my schedule.
Yeah. Shina, any idea about that?
Yeah,
to handle?
This is an excellent point you brought out, and actually Antonio mentioned that retrograde menstruation is not the only cause, and that is true. There is a publication from Signorelli from Italy that they did autopsy on fetuses and they found endometriosis. So there are multiple reasons, and nowadays early detection of adolescent endometriosis is very important. Because in the last 2 years, because of the COVID and no travel, actually, I put the group together. We published a book on adolescent endometriosis, which has never been done. And being aware, listening to the patient, being cognizant about these symptoms. We looked at one of the papers we published about 10 years ago. By the time a teenager, adolescent is diagnosed with endometriosis, they have seen up to 10 different specialties. And it could take average 7 years to get a true diagnosis. So these are all excellent points. We just have to listen to them.
Sure, I think I could concur with all the remarks, because of course, if you have an adolescent, the problem of vaginal ultrasound, then it's very difficult, and so we'll have to drive on the history and as Anneli says, and follow up the patient, and then the only thing we can do is a full bladder abdominal ultrasound to make sure that we don't miss a endometrioma. That's about the thing you can do, because rectal examination is not actually appropriate even with these younger people. And so, I think that following and not leaving the patient, but discussing the patient. And that is the point that Sheena makes. If we actually just let's see them, then they go to someone else because they don't trust you. You have to gain the trust of the patient, and then from there follow them. And when you're when it becomes unbearable, you can still go in for a more invasive exam like a laparoscopy, I suppose. That is how we handled it at our department since years. Yeah. Is that okay, Bash, or what would you suggest?
No. I'm in agreement with everybody on the panel. Sina, I thought it's only my problem in South Africa where I see a patient with 7 laparoscopies and she hasn't been any better than what she started off with. So somewhere in this whole thing, maybe in Europe it's different because it's national health and everything is clear and cut but in private practice, people put in a telescope to have a look, fiddle a little, and walk out again until they say, go and see Sinat. He's the expert. Now you got a stuffed up pelvis, and they send it to you. So it seems that worldwide we lack training of intense surgical skill to address endometriosis patients' outcome. Maybe the message out there, Antonio, is if you can't tackle the lesion appropriately, back off and refer to an expert unit. I think this message is not coming out aggressively enough, and we are doing disservice to patients who look up to the profession to solve my problem. You know I have endometriosis, but I'm not getting the relief that I'm expecting. I'll be so happy to hear from the panel.
Yeah, that's extremely important. And I perfectly agree with Anneli. If the medical treatments fail, this is the time to perform laparoscopy, even because we have to offer the best management to our women. If the pain continues too much time in the life of the patient, the pain becomes from somatic to neuropathic, and then we will have a highway from the periphery to the central nervous system for pain. And sometimes, even if we remove endometriosis properly, the pain is still there. So this is extremely important because we have to do early management of our women with appropriate setting. If I'm not able to perform endometriosis surgery, I leave it and I will refer the patient to another one that is more skilled than me.
Any comments, Anneli?
Thank you very much for all the comments. I'm just excited all this topic all the time, and trying to also advocate information forward. So that is another problem I'm facing, that sometimes people, I'm working in this kind of hospital that they know that I'm an expert in endometriosis, but if they end up in some other gynecologist and she doesn't know about this and doesn't care, though it takes a long years before that adolescent, she becomes 20, goes to university and still suffers, and finally at the age of 25 gets the diagnosis. So this is kind of a very sad story, and it's still happening. So the other thing we have to do is really advocate and teach, and this is not the bad knowledge. It's they just have to remember that the endometriosis may start very early, and we can really save those girls from very terrible disease by diagnosing them early and getting really the proper diagnosis and the information for the patients and the family, and then get them followed up. Because usually a 15-year-old doesn't come to a gynecologist. Usually they come to a gynecologist when they really start sexual intercourse. And a 15-year-old who has already had 2 or 3 years of menstruation and has a pain, then I actually do rectal ultrasound very, gently. And I have managed most of my young patients very well. So you have to have a lot of discussion beforehand, and they can deal with it. So it's not impossible. I do rectal ultrasound very often. I don't touch the vagina when there are Virgos, but when I get the diagnosis and I can talk with the family, I think that this is really a win for the patient. So I suggest that for everybody. So don't be afraid of a 15-year-old just because she's 15-year-old.
Can you agree with that, Bash? But I think you mostly see the young girls together with the mother, so you have to convince the mother more than the young girl, I suppose.
I have to admit that very often the mother is first my patient, and I cut the endometriosis out, and then they start to bring the daughters because I talk about the genetical situation also. So, and they very fast, they also distribute the information through social media. We have this kind of social media for endometriosis patients in Finland, and the information spreads well. I'm very grateful for that. And young patients also find already doctors. So this is important, that the 15-year-old who doesn't have sexual intercourse may be suffering for endometriosis, and she has to get an appointment to gynecologist, not to wait until she gets an intercourse.
Bruno, just a small point of view. The mother is always in collaboration with the gynecologist. She exactly knows. It's for her to be told. We think that we've tried the medical therapy, we've given it our best shot, it hasn't worked. There is a possibility to do a laparoscopy, and she will not say no. That's the relationship that ultimately develops between the gynecologist, the mother, and the young daughter. Can I make a small point, and I want Sina's input? Sina, you think there is a place for the gynecology fraternity to have a joint session with the gastroenterologist, who invariably will end up doing colonoscopy and find nothing, because majority of the patients that come to me have had a colonoscopy, and of course gastroscopy is just thrown in as a we do a G and a C scope for every patient that has got abdominal pain. We will be able to educate the people whose referral will be so timeous to us.
But you have to do it with the pediatricians, to educate the pediatricians, to tell them she is not skipping school. You have to educate gastrologists that is not irritable bowel syndrome.
Correct.
You have to educate urologists that this is not interstitial cystitis. Unfortunately, this is the mentality going out there. I get more referral from psychiatrists or the social counselors than I get it from pediatricians.
Okay.
So this is a global problem, unfortunately.
I think so. That could be one of the aims of or the scopes of our task force on endometriosis, Anneli, to maybe let's say put some things on paper and then on the net and as you say on the social media, not recommendations, but maybe just let's say our way of thinking, so that people can hold to that, and I think that would be worthwhile trying to do something like that. Because the papers we send out, and the last paper in the Trocar were mainly aimed for the surgeons, but I think there is a lot more. Surgery is about 80, let's say 20%, 80% is before the surgery, and I think that's extremely important, as all of us agree on that, I suppose, at this moment in time. What do you think, Antonio?
I perfectly agree. What was coming in my mind when I was listening to all of you is that probably we have also to come back to the basic. I will try to explain what I mean. Usually, as I said during my presentation, but I would like to stress once again, when my trainees is in the endometriosis outpatient clinic, always start with ultrasound, even transvaginal sonography. Why? I would like to break their hands. Start with vaginal examination. What they were teaching me is always to start with bimanual vaginal examination, because it will give you a lot of useful information. And I don't know if you agree also with this point. Sure. To come back to the real vaginal examination. Let's think about the rectovaginal septum. Okay, you are not skilled enough to identify endometriotic lesion of the rectovaginal septum, but you can feel it. You can understand if that is painful or not, and it requires surgery or not, just with the fingers. So probably we are also to come back to the vaginal examination.
I agree with all these comments. I really enjoyed your talk and this discussion, but it's my clinic hour. So if it's okay, I'll say goodbye to everybody and so long.
Goodbye. Thanks a lot, Cina, for joining.
Well, nice to have spoken to you. Keep well.
Sure.
Thank you, Cina.
Well, the problem seems to be that there was a misunderstanding on the initial hour that we went online. It was the Central European summertime, and so a lot of our people they linked in about 1 hour late, and so but they followed the discussion, and of course everything the webinar itself and the discussion is for 1 month for everybody on the IAGaccreditation.org on the website, and so you can follow us there. Emmanuel from the Democratic Republic of Congo, he already told me that he will go back to the pre-recorded thing, and so I think I'm sorry about that, guys. Next time we will definitely put the CEST, but it's that is a problem from the actual platform. It's not. Sorry about that. What do you think? Is there anything else to discuss at this moment in time, or?
Bruno, sorry, I know it's long and it's getting late.
Go ahead.
But if we are going to do a comprehensive thing and people are going to see the recording, we might as well.
Sure.
Antonio, your pain mapping was excellent. I keep on learning every time, though we all have operated so many times. The concept of sharing the skill of pain mapping will help you to diagnose accurately exactly what you're going to find when you put in the laparoscope, so that you know you are well prepared of what to do in the surgical procedure. I think maybe worldwide there is a shortage of good skill to do justice to stage 2 and 3. Even simple, straightforward endometrioma is not that simple, straightforward, because if there's recurrence, means somehow, whether you did stripping or whether you did an ablation, whether you did high frequency sort of destruction, whatever you're going to do, you have to be able to sort of show as many videos prepared on an idiot's guide to endometrioma surgical management. Antonio, that's your homework.
I perfectly agree. And the point of the pain mapping, in my honest opinion, is extremely important for a proper management, because we have to perform tailored approach.
what I mean. If I found a small lesion on the left uterosacral ligament, for example, for instance, but that lesion is painful, but it doesn't affect the quality of life of the patient. It doesn't affect the sexual quality of the patient. The patient would like to leave it there. What I do is counsel the patient and then delay the surgery and treat her with the pharmacological approach. If the pain will stay there, then we will rediscuss the case for OR. But for example, in this moment, we do not have any data, any literature, any publication about removing or not removing painful lesion only. I mean, if I have this small lesion on the left uterosacral ligament and I would like to remove this lesion, of course, I have to enter in the retroperitoneum, isolate the ureter, and then cut the uterosacral ligament. And in that moment, I could make the image. So the patient has to be informed about this. It is not so simple. I found endometriotic lesion and I will remove it. We have to discuss about all the potential effect of the pharmacological treatment of the laparoscopic approach, what can be the potential damage, the potential complication, and together with the patient, we will find the right pathway for her.
I agree with that. There is a question from Yasser Abdelal. We are in need for guidelines to classify patients according to their presentations and severity of the conditions. Well, Yasser, I would say in the last number of the Trocar, in the last volume that is volume 3, issue 1, you will find an article by Jörg Eckstein where we try to actually combine the Atensian classification with the severity of the lesion, and if you combine that with the article in the European journal that Antonio brought in his lecture, then you'll see that you could actually more or less define the severity, the presentation of the symptoms and the severity of the lesions, and then you can correlate that with surgery. But actually, what we now discussed, and I think it's almost so important, that is that actually you cannot just go for the severity of the pain sensation, but that actually you have to see the whole picture, like it was again pointed out by Antonio, that you have to go for the whole picture and then see how far you come in every single patient. There's no such thing that you can actually classify the patients according to what's happening around. It's easier to do that for surgery, but it's not that easy to do it for patients that complaining of pain. Of discomfort and pain. Then there is a question or there is a comment from Ahmed El Arian. Well, my pronunciation is of course not a home tongue. Concerning the imaging, is it necessary to use an MRI in diagnosing and localizing endometriosis, or ultrasound under supervision of an experienced endometriosis-oriented ultrasonographer? I think that Antonio, you can stress that again, what you said about an MRI, and I'm sorry that we missed this for most of the people, that they linked in too late. But can you just repeat your position about the MRI and the ultrasound?
Yes, in according to the literature and also my experience, inexperience is not a good justification to ask for MRI scan. For a proper reason, even if the radiologist is very good but has no experience with the pelvic examination with ultrasound, risk to miss the endometriosis diagnosis. So according to my experience, it's better to perform a good transvaginal sonography compared to a bad MRI scan.
I agree completely with that, because also if you perform, the thing is, of course, that in some countries it is also a technician that does the imaging, the ultrasound, and I think we have to not only educate people in the history of the patient, but also once again in doing the ultrasound, because I think that it is mandatory, especially for these patients, that it is the surgeon himself or the gynecologist, to put it broader, to do the ultrasound, so that you're in contact with the patient and you do a rectal ultrasound if necessary, and you have to talk to the patient and feel. And actually, the ultrasound should be the prolongation of your fingers, of your, and that is what also was pointed out by Antonio, I think. And then it is far better than most of the technical exams like an MRI. Again, if you go to the IAG.org, the Trocar, you'll find the article by Jörg Keckstein, and you'll see how he deals with that too. And so I believe that Antonio is very right, that you start with your history, you then go for a clinical examination, and then you go for an ultrasound. And the ultrasound is actually just a prolongation of your clinical examination.
Bruno, can I, Antonio,
yes,
my apologies. I'm sorry.
No, it's okay. I would like just to underline that it's very cheap and you can perform ultrasound every time you want. You are not sure, perform another ultrasound.
Bruno, can I come back to simple things?
Sure.
If there is a question, how do you prevent recurrence of endometrioma post-surgery? Should you be stripping? Should you be using plasma kinetic energy? Should you be using argon beam as an energy to destroy the pseudocyst that is present? And sometimes it's not possible, if you have a thin pseudocyst, to do a stripping procedure, because the walls are very thin and you cannot separate the external aspect of the ovary to the pseudocyst on the inside. Therein lies the choice by the surgeon, because you try and strip a very thin cyst wall, you're going to tear the ovary and do more harm than any good, number one. Number two, stripping is regarded as the gold standard, but you get the prevention of recurrence, but destruction of the residual ova, and you may not be a very happy person at the end of the procedure with the infertility in the background. Argon beam destruction, I'm using it for more than 30 years. For whatever reason, and I find it there is a complementary play between stripping and destruction of the pseudocyst by an energy of that nature. Then obviously the people from France are using plasma kinetic energy to try and also destroy the pseudocyst of endometrioma. How do you prevent recurrence of endometrioma resection? Recurrence. I'll be happy to hear from Annalie. Let's see what does the world do out there. We all are in different parts of the world.
I'm sorry, did I understand that the question was for me?
Yes, because you're the lady.
The first comment is for you, yes. Yeah.
Thank you for a very difficult question. So I listened to you very carefully, but I think I didn't hear a word sclerotherapy. That is also a new kid in the blog. And so you put alcohol of 95% of ethanol inside an endometrioma, and you leave it for 15 minutes and then take it out and you rinse. But that is not going to make the recurrence less. It's going to make recurrence more compared to stripping. The problem is always, is it the first surgery or is it the reoperation? So, and what is the ovarian reserve? The third thing is the age of the patient. So I always, if we talk about endometrioma and we go to the surgery because of pain, then usually I don't use any of these energies you mentioned. I use plain stripping or combined techniques. So if really, there are very few times I didn't get the capsule of the endometriomas. And if I don't get the end of the capsule, then I use some kind of a small energy burst there. I do use bipolar, I have to admit, but only at that point that is left. The rest I strip and I try to use, I try to save the ovary. But if it's a recurrent endometrioma, and the patient wants to have a baby, then it's going to be a discussion with infertility specialists. There are some patients who I have sent to artificial reproductive treatment with endometriomas of 5, 6, 7 centimeters because they stimulate the follicles first, even they freeze the embryos, and then maybe we just drain the cyst, and I didn't start sclerotherapy yet, but then we are very gentle really with the ovary. But if it's the first case and when it's only unilocular, it's only one side, then it's usually stripping. And of course there is a new paradoxal idea that the recurrence of endometrioma is not actually that bad. It doesn't show the bad work of a surgeon. It shows the good work of a surgeon because the vascularization of the ovary is so good that endometrioma can come back. So if you destroy the ovary, then the endometrioma doesn't come back because you burned it, and it doesn't get any hormones from there. But that's one paradoxical idea of this. So how to avoid the recurrence, I always use a secondary pills, secondary prevention. So I start birth control pills always after surgery if the person doesn't want to have a baby, and if she does want to have a baby, then she starts to try, and if there is no baby, then I refer her to infertility specialist. So that is my schedule usually, but when it's recurrent endometrioma, I will be very careful with surgery again.
I can totally agree with that. I think, Bash, that the golden standard, as you say, is stripping of the cyst, and in most cases, with the technique of actually bringing some liquid, like you also do behind the cyst wall, you can strip most of it. There is only two randomized controlled trials. And the one is from the most known, and the first one is from Paolo Beretta, who worked with me in Antwerp when we made that approach. And actually, in the last issue of the Trocar, the issue 1 of this year, you'll find a video article by Amene Ago of Tehran, who actually explains that after what we call now a conservative approach by stripping the anti-Mullerian hormone, after a while comes back to more or less normal let's say, levels. The thing is if you start burning it, be it bipolar, and I would certainly not do it with the excited plasmas. With the excited plasmas, you don't even have an idea how far you actually, they are supposed to be very superficial, but actually they go farther. It is a bit like carbon dioxide laser that we used extensively in the past. We don't use it anymore, more or less, in gynecology. Some people still do, but there you're very superficial, but it also depends on the time that you're on the tissues and on the intensity of your signal. And that is the same thing as for the let's say the other energies. And so I agree that stripping is the best and for a first time approach. And we did now talking about years ago when we had when we did a lot of falloposcopy, we also did cystoscopy in the endometrioma. And what you then realize is that an endometrioma is just filled with chocolate, but actually it's only on very specific points that you find endometriosis, endometrial cells. All the rest of the capsula is normal and is just a capsula. And that is an external capsula, because the endometriosis tends to come from the outside and then pushes the theca away, and you got your capsula. And so that is the reason why it's it's not that easy, but it is possible in most cases in a first approach. But I agree totally with Anneli when she says that for a second one, and we had our own IVF center for a while, and so chocolate cysts as such, the idea that there was that the actual eggs were not that good, but actually if we look at now on the longer term, the results of IVF are not that bad, and definitely not in a way that bad that we should avoid to do it. And so I would say for a secondary endometrioma, Anneli is right. That means that there is enough let's say vascularity to the ovary, and so that is a good thing. And so then you got also the rest, but we have to adapt patient by patient, and the first approach is different from the latter approach. I would also not use glues if you want to close it, because then you got chemical toxicity in most of the cases. So a simple stitch is easier if you're able to suture. So that is not a real problem, I think. Is that also what you think, Antonio, or do you want to add something to that?
Yeah, thanks for the wonderful conversation, because I'd love to continue for hours. So regarding this point, I am a very simple guy. I am not a genius, so I try to be smart. First of all, I select very carefully patients. So if I have an endometrioma that is less than 3 centimeters, it's very, very, very rarely that I took the patient to OR.
Sure.
Second, the indication for surgery. If the patient has pain, is completely different from patient with infertility. I mean, if I found an endometrioma of 6 centimeters, the patient is concerned for fertility, and the anti-Mullerian hormone is 0.2, what is the meaning to bring this patient to OR to improve the fertility? Because the anti-Mullerian hormone is already 0. So you have to be honest with the patient and say, if I will remove that big endometrioma from the ovaries, your reproductive outcomes will not improve, because the ovarian reserve is approximately 0. So the second thing is to be honest with the patient. When I bring patient with endometrioma in my OR, I never use pre-treatment with hormonal drugs, progestins, combined oral contraceptives, and etc. Because probably I'm not skilled enough, but I would like to find a good cleavage plane when I perform the cystectomy. And old but gold, I always perform ovarian stripping and then suturing of the ovarian cortex in order to reduce the bipolar coagulation as much as possible. I was trained in the school of Ljubljana in Slovenia. They were teaching me this type of stuff, and it was always good. The second point is that after the surgery, if the patient, of course, would like to conceive spontaneously and is young, I mean below 35 years, has a good ovarian reserve, I will let her to try to conceive spontaneously. Conversely, I will send her directly to IVF. If the patient doesn't want pregnancy, in that moment, I will put her on hormonal treatment. I mean, a combined oral contraceptive, progestinol in therapy, because so far in our guidelines all over the world, the American Society guidelines, the European Society guidelines, there is no post-operative therapy that is better than another to prevent recurrence. So also about this point, we have to be honest with the patient. And sometimes, and I will stop my comment, we have to keep in mind that the endometrioma per se, so without surgery, is detrimental for the ovarian reserve. So if we keep the endometrioma there, that ovary will have a decline of the ovarian reserve that is worse compared to the healthy ovary. So we have to inform the patient also about this point. It's not just the surgery that decrease the ovarian reserve, but also the endometrioma per se. And finally, and I will stop, we have also another possibility. When we have a ovarian endometrioma and we will address the patient to in vitro fertilization, during the ovarian pickup, we can make a puncture of the endometrioma, aspirate, just make antibiotics, and that's it. So we would don't be scared to aspirate endometrioma during IVF.
I agree with that. There is another question from Ahmed. I would like also to ask if it's justifiable to use GnRH antagonists for long periods, years before the young patients are ready to conceive. Anelli, can you answer that?
Yes, thank you for a good question. Unfortunately, I'm not IVF expert, so I have other doctors for that. And I don't know if they use GnRH antagonists. So we use only analogs. And analogs, sometimes I use when I suggest this to patient, and we do this together with IVF expert who says to me what they plan with the patient. So sometimes I put them on 3 months of GnRH analogs and they do well, and then the IVF expert takes them kind of over and starts to stimulate after that. So we do cooperation with that. And sometimes it's longer, but GnRH analogs I use, not antagonists.
No. I would agree with that, but you have to be careful with GnRH agonists as well, because we had, well, it is very rare, but you got we had a problem with osteoporosis with one of our patients that actually in our IVF center, actually after 2 injections of GnRH agonist, actually presented with an aseptic hip necrosis. So that is a possibility. You have to be careful, and you have to, if you give it for very long periods, you really have to make sure that you know about the bone density of your patients. These medications are strong, and you have to be careful with them. And I would not do that after laparoscopy for chocolate cyst, Ahmed. I would really, as already told, the chocolate cyst is not the end of the world, and we'll have to come back from trying to be too, let's say, too aggressive in endometrioma. That's my belief, but it is just an experience for some 35, 40 years.
Thank you for the comment. That's my maximum time I use GnRH analogs is 6 months, and usually it's HRT supported, so I use add-back therapy very often. But I usually don't use longer cycles. So thank you.
Any other questions? Please, Anneli, go ahead.
I would like to thank Antonio once again about the pointing out the vaginal status and the clinical workup. Actually, we are entering the era of neuropelviology, and neuropelviology you don't do with ultrasound, you do with clinical assessment. So the first thing is how the patient walks in, how she sits. Does she sit on the one buttock? Does she some kind of, is there, if she goes to the gynecological procedure table, you can see is there asymmetry. So the first thing I already do is I inspect. I use my not only I listen to the patient, but I also look how the patient walks. So then comes the dermatomes. Then I will see where is the pain, where is the sensitivity, the dullness, where is everything? And then I start to do my vaginal rectovaginal inspection before ultrasound, everything, because then I get much information where to look something. And that's also a problem in ultrasound, that if you don't get information from the history and from the clinical status and then the objective status, the vaginal status, then you may miss with ultrasound because you forget to look there, or you get much information to do the ultrasound. So I suggest very much to learn and get familiar with neuropelviology, and that is, I think, it's becoming mandatory in the field of endometriosis status, because it's impossible to find these people, and I think it's going to be a problematic, because you will have these patients, like Bruno said, that endometriosis goes into the nerves, and we have to find those patients, and we have to refer these to the special centers that take care of these patients, because as all neuropelviological surgeons says, if you have to go to make neural endometriosis surgery the second time, they don't want to do that. So exactly. that's just terrible, because there are coming fibrosis and everything. So that's really one shot thing. You may do chocolate cyst maybe twice, and you may do peritoneal endometriosis twice, and you go there and take another session of sacrouterine ligaments endometriosis, but not neural endometriosis. Neural endometriosis is totally one shot thing, and it has to do the expert only. So everybody who is dealing with endometriosis patients have to be familiar with neuropelviology and start their studying that. So I'm very, very much agreeing with you that ultrasound is after the clinical status, not the first line.
Bash, any comment?
No. Bruno, just to say to Antonio, thanks for an excellent presentation. You covered the basics. We don't want to talk bowel resection. We want to talk correct diagnosis, correct evaluation, correct guidance to the patient. You brought that out diligently, Antonio. Thank you very much for an excellent presentation. And my colleagues out there, Bruno, thank you very, very much for moderating this, and wish you guys well over the weekend.
Thanks a lot, Bash. Any last word, Antonio? Or
I would like just to thanks for everyone, the audience, all the chairman and chairwomen, because every time I have this type of discussion, I learn something new. So thank you for what you were teaching me today.
So thank you very much, everybody. And I see that at the end, when people actually realized that we were discussing, they stayed with us the whole time. Well, the totality of the recording is, as I said, on IHE baraccreditation.org for 1 month, and then we bring it on the IHE.org on the syllabus, but that is for members only. So thank you again, Antonio. Thank you, Anneli. Thank you, Bash. And also Sheena, who made the time to come out of his practice to stay with us and to discuss. And I hope you have a wonderful weekend. Thank you very much. Thank you. Bye-bye for now.
Thank you, Antonio,
Bye-bye.
Anneli. Bye.
Thank you,
Thank you.
Antonio.
Bye.
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 Bye. Dirk, you can close the proceedings. Huh?
Okay, I'm going to close the webinar, all right?
Yes.
Okay, thank you.
Bye-bye.
Okay, bye-bye, everybody.
Bye. Thank you very much.
Thank you. Bye.